Hello, everyone, and welcome to CLS Live, a live stream series presented by the publishers of Contact Lens Spectrum. I am your host again, Jason Jedlicka, and I want to thank you for taking the time to tune in to today's episode. Each program, I have the chance to chat with a leader in the world of contact lenses, finding out what's going on in the contact lens industry from their perspective and with their insights. We talk about new and future products, the latest research, worldwide trends in prescribing, and even bring you updates from the floor of contact lens conferences. So for today's episode, we'll circle back to that hottest of topics, myopia management. We talked a couple months ago, if you recall, with Mark Bullimore, and today we'll turn to another of the world's experts, Dr. Kate Gifford, for her insights into myopia, or as I like to call it, progressive axial length elongation. Dr. Gifford is an internationally renowned clinician, scientist, optometrist, and peer educator, and a visiting research fellow at Queensland University of Technology, Australia. She holds a PhD in contact lens optics in myopia, 4 professional fellowships, and over 80 peer-reviewed and professional publications, and has presented a whole lot of conference lectures. Kate is the chair of the Clinical Management Guidelines Committee of the International Myopia Institute and lead author of the landmark 2019 paper and 2021 digest by that committee. In 2016, Kate and her husband, optometrist Dr. Paul Gifford, co-founded Myopia Profile, the world-leading educational platform on childhood myopia management, which she now does full-time. Well, Kate, welcome to the show. We've had a little interesting chat about your travels and all over Australia. Thank you for taking the time to be here today. And we are officially living in 2 different days, aren't we?
Yeah, well, I'm coming to you from Wednesday, so thank you for
Correct.
welcoming me, Jason, from Wednesday. You're still stuck on Tuesday.
I am.
Wednesday seems good so far.
Yeah, I think I'm actually living in the past now, physically, truthfully. So, but anyway, it's great to have you here and up early. Fortunately, our time is not too bad. It's kind of a normal waking time for you now, so we didn't have to dig you up in the middle of the night, at least.
No, and I have done that for many overseas conferences in this era of virtual conferencing. I've had 2:30, 3 a.m. calls, those sorts of things. So you've got me. I think you've got my full brain on board because
Perfect.
It's 8 in the morning. So
you had your
full
coffee
brain,
already,
ready to have this chat.
Your coffee, your tea already. So hopefully,
yeah, all good, ready to go.
Well, good. So I've read your bio for those who didn't know about your background, but tell me a little bit more about how you decided upon myopia for the focus of what you do, or is there more to life than myopia for you, or is that pretty much the focus of everything right now?
Well, I think let's on a slightly wider picture. I think as time goes on, we all have to find other things in our life aside from work. So life isn't entirely about myopia, but for the most part, I guess it is about myopia. And it's an interesting question about how I got to this point, because if I look back, when I graduated from university, which is nearly 20 years ago now, I was keenly interested in binocular vision and contact lenses. And that was a bit of an unusual way to be at the time. It was more typical that you were interested in binocular vision and pediatrics or contact lenses or neither, but it was unusual that it was both. And I think that my interest in myopia really grew from merging those two. So my final year research project was in orthokeratology, and I eventually had that published as a paper. And the first evidence for myopia control was in orthokeratology back in 2005. So if we think about the myopia research that was happening back at that time, it was, the first indication was orthokeratology, and the other things that people were trialing in research studies for myopia control were progressive edition glasses or bifocal spectacles. There was even, digging back into it, some very early studies on atropine, but I don't think I was aware of that at the time. What I was aware of is that myopia management seemed to be that real blend of binocular vision and contact lenses. And I've also always been really interested in the academic and the research side of things. And so I've always been interested in reading the science and seeing how can I take that and apply that to, the next best thing. What's the cutting edge evidence-based thing I can do for my patients? And myopia has just been such an exciting field for that over the past, well, especially over the past 5 years. But even looking back over the past 10, 15 years, we've learned so much. So being able to do that now on a global scale, being able to read the latest research and help my colleagues see what that means for patient care is really exciting stuff.
Yeah, I think it's interesting that you brought up about, a lot of the people who were early into myopia management are contact lens people. And that's because kind of at the time, that was really the only concept of how we might manage it was contact lenses. So, like at our university, being the contact lens chief, we've kind of been into myopia management for, like you said, for 5 or 10 years. But just in the last year or two, a lot of the management is shifting to our pediatrics department, and we're coming alongside them for the contact lens work, but they're managing the whole picture. So I do think there's an evolution in how we manage it. And maybe it's not just the contact lens person that's going to be the only person, but maybe they're just part of a team now, possibly. So
Yeah.
if I can ask you, because you have such a extensive background in myopia and you do look at all the research and you do educate the world about it in many ways. Go back 20 years ago, like you said, when you came out, and what your concept of why people got myopia was, and how that has changed to now. Do you have a different perspective on the environmental versus the inherited aspects of it?
Yeah, that's a really interesting question, and I think if I go back 20 years, my memory is a little bit woolly because it's a little while ago now, but we weren't taught anything about myopia control at university because it wasn't really a thing. There was, if I look back now at what had been published at the time, it was a couple of unsuccessful studies really on bifocal or progressive lenses and nothing really measuring axial length. So the evolution of contact lenses, as you said, has been a really important part of where myopia control and myopia management really started from. But I think 20 years ago, we really thought that myopia was genetic, and maybe it was, that was the key driving factor. But the more and more research has amassed over the past decade or two, the more we understand that it is more environmental and that the growth of myopia is moving too quickly to just be genetic.
Yeah.
So we understand that people who become myopic are likely to, I guess, if we put this in a simple way, the likely driving factors in terms of environment can be put simply as not enough green time and too much screen time, although it's asterisk conditions apply with the screen time because we haven't yet teased out what the influence of screens might be as compared to just near work in general. But that's the environmental influences. Lots and lots of near work, close working distances, not enough breaks, and not enough time spent outdoors. The interesting thing about genetics and environment is that they do interplay. But what we understand now is that the biggest risk of you becoming myopic is not being as hyperopic as you should be at a young age. And the biggest risk of you becoming a high myope or having faster progression is younger age. And that's independent now of genetics and ethnicity. So those individual factors, genetics might play a role into development of those individual factors, but those appear to be the biggest driver now of myopia development and progression.
I think something you said that really I hadn't thought about honestly before, and I'm a big believer, that I've been a big believer for many years that it's multifactorial, that there's probably some inherited risk that your eye tissue is somehow more malleable, and then whatever you do affects that. And so, but I never thought about the fact that if you go back, many, many years ago, the genetic component might have been the major aspect of it. And as we've changed our behavior, the behavioral part has become a bigger part of it. I never thought about the fact that, that there was a shift maybe away from most of it being genetic to now a lot of it being behavioral. I never thought about that shift in where it's coming from these days, but it certainly makes a lot of sense. So
yeah, and it might be hard to sort of define an inflection point. I guess people might think, oh, 2007 is when we got iPhones, but it wasn't immediately that every kid had an iPhone. You know, I didn't have a smartphone until I think 2009. It didn't even really work properly. So, you know, it wasn't something that was ubiquitous. It could be hard to define. There are other elements like educational pressures, particularly in Asian countries, that are correlated with increasing rates of myopia as well. So it could be hard to pick a point at which, you know, it might not be a flip. It's been a evolution
yeah,
of
and
the
I
human
think
race towards bigger eyeballs, which is not
yeah,
a good thing, as we know now.
and just the urbanization of humanity, I think is a part of that as well, for sure.
Yeah,
Um,
yeah.
Well, I'd like to take a moment just to talk, and I want to get to this international perspective on myopia. And as we lead into that, just real briefly, I want to talk about a conference which you're involved with, and that is the Global Myopia Symposium, or the GMS. You're on the planning committee for this conference, and this meeting truly, as much as like the GSLS for contact lenses is international, GMS is probably even more so, because most of the thinking and research into myopia, and most of myopia management has been done in other parts of the world outside of the US for the bulk of the time. Talk a little bit about how you got involved, and tell us a little bit more about the meeting in general for someone who hasn't been to one before, what they'd expect to see and learn and find at this conference.
Yeah, sure. Well, the Global Myopia Symposium was held for the first time virtually in 2020. It was held virtually again in 2021. And this year it's being held again in September 9 to 11. And it's most likely going to be virtual again. I got involved right from the outset. And right from the outset, I was very keen, as was the entire planning committee, for us to really put the global into Global Myopia Symposium. And that's meant a variety of elements of evolution of the program. So last year, for example, we had a whole session, a half day, which was run concurrently with the Asia Optometric Congress. And that was actually the most heavily attended session. And it's really important that we have a global view, because what's important for us to uptake myopia management for each single patient that we see. But the largest by population concentration of myopes is not in the US, it's in Asia.
For sure.
And so we really need to get this message out. We need to get this message out to make the biggest difference in every country, but also to make sure that we really are getting this information to where we have the greatest concentration of myopes. So GMS is really designed to be global. We have speakers from all over the world, which is very important. We had attendees last year from something like 80 countries, I think, which is wonderful. And we're really, really focused on the practical aspects. So something we decided right from the outset is we didn't want to spend a lot of time talking about global growth of myopia and risk factors and all of that sort of stuff. You know, we could have a bit of that foundational information at the start of the conference, and then the whole rest of the conference needed to be focused on practical aspects, whether that be understanding treatments, whether that be understanding processes, the business side of putting myopia management into practice. That practical element is the real focus.
So for somebody who is practicing optometrist who has an interest and wants to grow and develop this as part of their practice more and more, this is a very practical meeting for them to attend then. And easy because it's virtual, so they'll have the opportunity to attend from wherever they are and get a lot of real clinically implementable strategies for managing myopia on their own.
Yeah, absolutely. It's really designed to be evidence-based, but intensely practical. Case studies, treatments, all of this sort of stuff. So just as you said, that person, that colleague of ours can really work out what they're going to do next to improve their myopia management in practice.
Awesome. Well, hopefully everybody who's watching this is going to have some kind of contact between now and September about signing up to attend, and look forward to that.
Can I add one thing? Can I add one more GMS thing?
Yes.
So at the moment, we've got a call for courses and workshops out, which closes on February 15. So if you have ideas out there, listeners, for 1-hour courses or 2-hour workshops, jump on the GMS website and submit those by February 15, because we get so many wonderful applications there, and then so many wonderful ideas on how to tailor our program from there. So if you want to get involved, you've got till February 15 to submit your course or workshop. Jason's writing that down, February 15.
Gave me an idea for a course.
Scribble that down.
I'm going to submit one now because I just thought of a good idea. All right, awesome.
Excellent.
All right, so we've got about 5 minutes. Gosh, this time is flying by.
It is flying.
I wanted to talk to you a little bit about this idea of managing myopia, because again, a lot of times we get so into our own little sphere or our region or our country and how we do things, but myopia, the epidemic of it, if you will, kind of started in Asia and it's trickling around the world now. But everybody's probably on a different scale with what they're doing to manage it. Again, I could be wrong, but I'm guessing that, for example, Australia probably is not one of the areas where it's blowing through the roof in terms of numbers, and yet you guys have a lot of the knowledge on how to manage it. So it's different by region of the world, and with myopia profile, you probably see more of how everybody's doing it than anybody. So can you talk just a little bit about how myopia is managed in North America versus Asia versus Australia, et cetera?
Yeah, well, I think that's a really interesting question, because right around the world, you're going to find the innovators and the early adopters in certain countries who are right up there, probably independent of their country of practice. The thing that's really fascinating about optometry as well is that the scope of practice is very different right across the world. So in the US and in Australia and in New Zealand, we can prescribe atropine. Most or all optometrists can prescribe atropine. That's not the case in pretty much everywhere else in the world. And so that makes myopia management look different. But we all prescribe glasses, we can all prescribe contact lenses, and we can all try to do something other than just prescribing single vision corrections to manage myopia. Now, the interesting thing about Australia is that we do have quite a lot of myopia, at least in our urban areas, because we do have a very high population of Asian ethnicity who are of greater risk of developing myopia. The interesting thing about Australia, and we are actually leading the world in terms of a couple of surveys that have been undertaken to gauge practices and attitudes in myopia. We are leading the way because we have a lot of access to products, we have a high scope of practice, and we don't have regulatory barriers to new products as much as what the US does. So we have access to more things, I guess, more products. In the US and in Asia and in the UK, there are a lot of parallels of where practitioners are really starting to understand now that myopia isn't just a pair of glasses, that it does need to be managed. And the access to products, especially in the last year or two, is really growing. So in terms of what's happening, we have a couple of surveys that were published in 2016 and 2020 on what's happening. But I really feel like over the past 2 years that will have changed again because of how access to these products is growing. So I think we're past the point of the very early adopters in most countries now, and more optometrists, because it really needs to start with optometry, even though it's multidisciplinary. More and more optometrists are becoming aware that they need to do something.
Correct. So 2 things before we wrap up. One is think about where we are now with management, and that is ortho-K. We have some soft multifocal lenses. We have, in some parts of the world, we have spectacle lenses that have peripheral blur, not here in the US yet. And then we have the atropine and the pharmacological interventions. Is there something else that's going to come along in the next 5, 10, 15 years that you can see that's going to be added to that? Or is something going to take over as the lead approach? What do you see with our therapies changing down the road?
So I think we have so many amazing products that have been researched or released in a small number of countries. So I think increasing access to products is going to be a big thing that's going to happen over the next couple of years. In terms of brand new approaches to treatment, perhaps we might have light emitting glasses for people whose for outdoor time it isn't as feasible. We definitely have some new research coming on formulations of atropine. There's so much more we need to understand about compounding versus commercial preparations and how that could potentially influence efficacy with atropine. But I think what's really going to happen over the next couple of years is us understanding more about these treatments, about for whom they best suit. And even as some recent research is telling us, how similar they might all be in terms of efficacy, such that we can really pick the solution that best fits that patient. So whether that be, that doesn't mean every patient needs to wear contact lenses or every patient needs to have atropine. If we have a pharmaceutical option, a contact lens option, or a few spectacle lens options that all have fairly similar efficacy, and I think we probably do at this point, just based on the early indications from research, that really means that we can tailor the treatment to the patient rather than trying to shove everyone into one box. So I think we're going to understand more and more about these treatments, and then about how it turns into practice in terms of combination treatments, combining atropine with optical treatments, when we should stop, how well do treatments work successively, all of these extra little elements. So I think we have most of the building blocks already.
Okay, so we just need to explore a little bit more how they can work together, and then refine our products so that they're maximally efficacious.
I think so, yeah.
The last thing I want to say is this, because you are kind of like the one who can change the world with this stuff, because of myopia profile, it's really big, and it's you have the influence to make this change. Can we somehow migrate away from thinking about myopia progression as a refractive condition and more to an ocular disease? So I teased at the beginning, myopia or progressive axial length elongation. Can we somehow recognize this is not just a refractive condition? Because if it was a refractive condition, it'd be far less bothersome. Can we relabel this can we give it a new name so we can focus on preserving the retinal health in this process?
Well, I could talk for another 20 minutes about this, so I'll try and give you a short answer. The short answer is yes, we have to. There is more than enough evidence now to indicate that myopia or progressive axial elongation, as you said, is a disease of the eye. And an analogy that we have used is likening myopic diopters, or millimeters of axial length, to IOP. So we all know that an IOP of 26 is, that might not cause damage to that patient, but it is likely to greatly increases the risk of damage to the optic nerve. And it's not something that a patient feels. It's not something that they necessarily see until it's really late in terms of symptoms of glaucoma. So if we think about 26 millimeters of axial length, the research has shown us that someone whose eye length is over 26 millimeters has at least a 1/4 risk of suffering vision impairment in their lifetime. And if their eyeball stretches to over 30 millimeters, that's 90%. 90% of people with super long eyeballs will suffer vision impairment in their lifetime. So in the same way that 26 millimeters of mercury is concerning, and it may be a problem, it may not be a problem, but increases our index of concern, and it's an invisible thing to a patient. Well, similarly, 26 millimeters of axial length is something that increases risk. This person may get myopic macular degeneration, they may not, but their risk is increased and they can't see or feel what that is. So if we can have that preventative eye health approach to glaucoma, we need to translate that to myopic diopters and even more so millimeters of axial length. It's a very powerful analogy, I think, for thinking about how we change our approach.
Yeah, I couldn't agree with you more. So, well, we need to wrap it up. Unfortunately, I think we could talk for another hour. This is such a great
Easy.
topic, and I'm having a great time talking to you about this and learning. But we do have to wrap it up. So again, thank you so much for being here. for getting up early and getting ready and getting started on your day a little early. Tell Paul thanks for staying out of the caravan while we're doing this. And just want to invite you all to, again, stay tuned for our next episode next month. We will have another episode of CLS Live where we will talk about something in the world of contact lens that's relevant and interesting and helps us all to do a better job of managing our patients. So thanks again, Kate. Thank you all for being here, and have a great rest of your day.
Thank you.